So I know many of those in attendance today are the physical therapists, athletic trainers, and not necessarily surgeons, but it's important to understand what we do in surgery. And for those surgeons, it's important to understand what the tips are for success. Now, I'm filling in for Rob Hunter. Rob could not give this talk today. He is recovering from some intervention that he needed for some part of his body. He's doing well from what I understand, but I'll try to do my best as we look at the tips. So top 10 pearls, we need to define what's being treated and make the correct diagnosis. Positioning is important. Portal placement is important. Visualization, the fluids that we use, the exam under anesthesia and the arthroscopic exam, we need to treat what is necessary. We need to mobilize the labrum and inferior glenohumeral ligament. We need to prepare the glenoid. The anchors, the placement and application of the tissue is important, and we need to have the correct instruments. And then finally, as we're talking about in these talks, rehab is critical. So the goals of instability surgery, arthroscopic surgery, are correction of the laxity, restore the glenoid containment, retention of the glenohumeral ligaments, and decrease the volume of the joint, plicate the capsule, and repair the tear. So we need to define who and what is being treated and make the correct diagnosis. We need to recognize bone loss. We need to look at a Hegel. Over to your left is a picture of a arthroscopic view with a large bone lesion. This actually could be treated arthroscopically, as we could reattach that. And to your right is what we call a Hegel lesion, where there's not a Bankart lesion, but the tissue, the ligamentous tissue called the inferior glenohumeral ligament has basically torn off from the portion of the humerus. We need a good preoperative exam and history, and Dr. Frank gave a great reasons why we do that. Imaging is helpful, and these are all essential to optimize a good outcome. And we need to recognize the right patient selection for the right surgery. This is more critical to consistent outcomes in surgical ability and technique. So we talked a little bit about lateral cubus versus beach chair. There's advantages to both. In the past, I was taught in the beach chair position. That's in the sitting position, as you see in the picture to your left. It was easy to convert to an open. Arthroscopic viewing is an upright anatomic position, and you can really manipulate the arm and the shoulder. However, as I learned during part of my fellowship and in practice, I found that my preferred position is the lateral decubitus. You get more distraction, better visualization, and easier to maneuver between the anterior and posterior. And as we've seen, there are better results with the lateral decubitus than the beach chair, and that's been my experience as well. So positioning pearls in the lateral decubitus, we need to align the body in about 20 to 30 degrees posterior tilt to keep the glenoid horizontal, and need about 10 pounds of traction, and then lateral distraction with this pulling up on the arm to help provide visualization. And then we can use a bump in the axilla if having difficulty visualizing inferiorly. So again, for many of you that aren't in the operating room, this may look a little bit foreign, but this is important for you to understand what we're doing to provide access to see inside. And this is the positioning that somebody would have at the time of surgery. Again, about 30 degrees tilt, and so that you're in the plane of the scapula. This is the traction and then the distraction, the traction and then distraction, where it's providing a little bit more room for us to move around inside the shoulder. So some pitfalls of positioning: overzealous traction and distraction. We need to feel the tension of the nerves in the upper arm, and we need to ensure that we have appropriate rolls, particularly in the axilla, to prevent pressure injuries, and also around the genitalia and also around the knee. Now, portal placement is very important. I use standard posterior portals, and then I use a second posterior inferior portal that will help, and you'll see in just a moment why that's so helpful. And then two anterior portals. One is high in the rotator interval, and the second is the top border of the subscapularis. So there should be 4 portals around the shoulder. Now this shows the a posterior inferior portal and kind of the area that we will go into, getting to the 6 o'clock position, deep inferior into the joint. So very important portal for us. Now, visualization is very important. We have to have appropriate fluid pressure and avoid turbulence. The turbulence creates poor visualization because due to Bernoulli's principle, if you remember that from physics, a force is created that sucks the blood from the capillaries. So we want to prevent that. We want to prevent that turbulence and that blood vessels and that blood from creating trouble and seeing in our view. Now, gravity fluid helps keeps constant pressure and avoids a turbulence. We put epinephrine in the bags, 1 to 1,000, and this helps with the visualization as well. Now, examination under anesthesia and an arthroscopic exam are very important. We must assess the anterior laxity, abduction with neutral and external rotation, and then we want to assess the posterior laxity. The direction of the instability is noted. So a very important part when we first get everybody asleep, and a wonderful time to get exactly how much laxity there is. Now, in the diagnostic examination, we want to look at the overall volume of the joint. We want to evaluate the biceps anchor, the labrum, the rotator cuff, the articular surfaces, the bony, any bony defects, and any capsular lesions or avulsions. If you look to your lower right on the screen, this is what a haggle might look like. We are looking into the muscle beyond the capsule. And so when we see this, we want to be able to understand and know and fix it. Now, we want to treat what is necessary. We don't want to overtreat. Be aware of the Buford complex. This is an area that is a cord-like middle glenohumeral ligament that looks like maybe there's a tear, there's the absence anterior superior labrum. However, this is normal variant of pathology. This is not a tear of the labrum as you look to the left. And then as you look to the right, this is an anterior superior labrum. And we want to make sure that we don't treat, that is not something that is, we don't want to overtreat. We don't want to treat something that doesn't need surgery. We want to mobilize the labrum and inferior glenohumeral ligament. This is done by elevating the tissue. We want to release the tissue at least to the 6 o'clock position. This is the anterior. We're releasing it. We can see the subscapularis below us. And then we want to prepare the glenoid. It's very important to prepare the bone. We want to get bleeding to stimulate healing. We want to visualize the anterior edge of the glenoid. And then we want to place anchors. And very important anchor for me is this 6 o'clock anchor that I can get through that posterior inferior portal. And we want to be able to do that. And we can do that because we have some technological advances. We have a curved guide. This allows for placement of anchors almost anywhere in the shoulder. Even works for the haggle lesion that we talked about. And this is what the 6 o'clock and that posterior inferior portal looks like. This is looking at a shoulder. This is a right shoulder on the side. The head is up to the left. This is coming down, and this is where the anchor comes down. This is looking from the top part of the glenoid. Scope is looking down, and this is what we call the 6 o'clock position. And this is what it looks like drilling that anchor. The anchor is going down inferiorly. You can see I have a great view all around. And then what we'll do is retrieve the suture from that anchor. Anchor is retrieved through the second anterior portal. I'm looking from the top anterior portal. And then using a suture hook that will help placate the tissue. And this is very helpful to eliminate any redundancy of the capsular tissue and allow things to be tightened up. And then I'll shuttle that the suture that I just pulled through the anterior portal. We'll shuttle that through the tissue that we just placated, and then we'll be able to tie that down. So you can see that having the right position, the right portal, and the right anchors is very important, and you can see as we're about to tie that. So anchors, placement, and plication, very important. Dr. Boileau from France has shown us that we need at least 4 anchors because less than 3 anchors in their study was associated with failure after stabilization. So very important to have enough anchors in the right position. And then I like to do the 6 o'clock and then a posterior inferior plication to complete the stabilization, and then also to complete and completely tension inferior glenohumeral ligament. So this is anterior to the right, inferior is below, and posterior inferior, very important. So the pearls, we want to liberally use these sutures, anchors at the edge of the glenoid to provide excellent secure fixation, especially if there's poor tissue. We want to be careful not to plunge too deep when we place this in there to avoid damage to the axillary nerve. And then we need the correct instruments, and there's a lot of different instruments to pass suture, and those are all very important. You can see a number of those there, and you can see how this is utilized as you saw. So lastly, rehab is critical. Use a small neutral pill immobilized for 6 weeks. We go slow, PT to start in 1 to 3 weeks. Start with external rotation 0 degrees at the side, then forward flexion 90 degrees. Start with isometrics. 4 to 6 weeks, rotator cuff exercise, lower trap and serratus. And then we start active stretching in 6 to 8 weeks. 12 weeks starts in proprioception, neuromuscular facilitation, plyometrics 3 to 4 months. Sport-specific training in 6 to 9 months, return to contact sports. Avoid too aggressive rehab, avoid lack of compliance, and avoid premature return to activity. So define what's being treated. Lateral cutis is preferred. Posterior inferior portal is terrific. Gravity fluid epinephrine helps with visualization. Need a good examination pre-op, examination under anesthesia, and arthroscopic exam. Don't miss the haggle. Mobilize the tissue to 6 o'clock position. Prep the glenoid. Retention and tighten the inferior glenohumeral ligament. Use a 6 o'clock anchor. The posterior inferior plication with the suture hook helps immensely. And then look and see what size, numbers, and anchor placement, and sling for 6 weeks with the correct rehabilitation. So with that, I thank you for the time to share that, and